Okay, welcome back everyone. In afternoon session, we will begin afternoon session with the focus on the weight gain. So in the next session, our next speaker is Assistant Professor Vasanamsit, Surgeon, MIS and Bariatric Surgeon at King Chulalongkorn Memorial Hospital. She will be discussing about the topic of diagnosis and investigations in weight gain and inadequate initial weight loss. Please welcome everyone.
Thank you for the privilege of the podium. I think we've talked about this topic pretty much sufficiently, this entire morning. So I'm gonna, kind of keep it brief in terms of the parts that are already covered and the parts that will be covered later on in the afternoon session. So the outline of this presentation are going to be standard definitions and revisional metabolic surgery, namely, inadequate weight loss and weight regain, which I think was previously brushed upon earlier as well. Important considerations of workup, especially from a surgical perspective, and then any expert consensus and then conclusions. So, as we've all heard before, initially, like before 2023, I think the main problem in trying to figure out, what is happening to patients after bariatric surgery is that there is no standardized definition. This changed in 2023 when IFSO issued a consensus on the clinical practice guidelines for obesity in terms of definition as well. So as you heard, recurrent weight gain is recurrent weight gain more than 30%, worsening of obesity complication that was significant. And then suboptimal initial clinical response, or non-responders, otherwise known as inadequate weight loss, is an initial total body weight or BMI loss of less than 20%, or inadequate improvement in obesity-related complications that were initially a significant contributor for wanting to do surgery in the first place. Now, with the increased usage of anti-obesity medications, I think it's important that when we have these definitions that we compare it to the same baseline. And according to these guidelines, when you initiate anti-obesity medication, like for instance GLP-1 agonist, that you define whether or not this was stopped pre-operatively. Because if you stop these medications before your bariatric surgery, then the baseline weight against which everything else should be compared is the initial weight before you start the anti-obesity medication. Whereas if you continued it, then the baseline weight against which, again, everything else is measured post-operatively to determine if or not you regain weight or had, inadequate weight loss is the weight on the day of surgery. All right, so we gotta make sure that we're using the same baseline criteria. Again, with the more standardized definition, I think this should be easier as well. As we previously heard, there are multiple factors that contribute to weight regain or inadequate weight loss. I'm not going to go too much into this, except it does immensely matter in your clinic when you're trying to work up these patients to try to figure out which or more than one of these factors are contributory to this. I mean, it's very easy to blame the patient and be like, oh yeah, you're not following the diet, you're obviously not exercising or like whatever, but like sometimes, many times in fact, there are other things that maybe should have been worked up or maybe should have been thought of before you even did the surgery to begin with, all right? Some of these things include things like mental health and eating disorders, like several different professors have already talked about, but like some of these could be caught before you even did surgery. And if you have like something that was well controlled pre-operatively, but they regressed back into their bad eating habits or their disorders, which have treatments, then they need to be treated. And the earlier you catch these, then the better the outcome. Like you shouldn't wait until it's like more of a salvage operation, but it should be like early detection and rescue. Other things that may be non-modifiable are genetics, which I'm not going to get into. There's a lot of research into that this moment about the genetic polymorphisms and things that are obesity related. I think these are not really that modifiable, but there are some suggestion that GLP-1 agonists in these scenarios may be helpful. Again, I experiment a lot with that, right? The main thing that I will focus on is your preoperative meaning preoperative to a revisional surgery, or sending them to other specialists with weight regain or inadequate weight loss. The initial history and physical exam in the office. I think this is probably one of the most important things that you can do for them to try to figure out what went wrong. All right. So So I think the first thing is, even if you did the surgery yourself, and especially if you didn't, then you define what the anatomy is, right? Just because the patient told you that they had a bypass does not mean that they had a bypass. A bypass in different parts of the world are not the same bypass that I or other people in the audience may understand it to be, all right? Like I had a patient who came and told me that a bypass, they did not have a good gastric bypass. It was, I don't even know what it was not that. And you can tell by doing a variety of different things. You can look through the CT scan, if they have one preoperatively, you can order a CT scan. You can do an upper GI study, you can do endoscopies, and we'll get into all of these in a second. Okay. What is the patient's current weight? Okay. And comparatively to the pre-op weight, and again, this depends, right, on how we define it. If they were on anti-obesity medications, the pre-op weight before they started that, if it was stopped pre-op, or the weight on the day of surgery, if it was not ever stopped before surgery, right? Is it by definition regain or inadequate weight loss to begin with, all right? Do they have other symptoms that need working on, all right? Because some of these are going to be technical, anatomic things that can be fixed. Some of them, not all the time, but sometimes, right? And these are, you know, the things that are going to clue you in are the presence of reflux or dysphagia, abdominal pain, especially the chronic abdominal pain, maybe something that needs looking into, nausea, vomiting, or malnutrition, which in this case is probably not so much of a factor if the problem is weight, right? Presence of anatomic issues like strictures, right? Especially things like when we have a dilated sleeve, for instance, sometimes there's a distal stricture that can cause osteodebilitation, for instance. Ulcers, history of ulcers, and you know, in hardware complications, if it was like, you know, a gastric fan, for instance. Fistulas, especially GG fistulas, when you have a lower gastric bypass that could cause, like, you know, weakening. Non-resolution or return of comorbidities. I think this is important too, that you define whether or not it actually went away and then came back, or never went away at all, right? Especially if it is one of the indications for performing surgery to begin with. Pattern of weight loss is basically what I said. Substance abuse, especially smoking, alcohol use, with some suggestion that contributes to like weight regain post-operatively. Presence of hiatal hernia, paraesophageal hernia, esophagitis, etc. Psychiatric conditions like we talked about a moment ago, and you know, other important things are reviewing the patient's diet, all right, exercise habits, what their expectations are in terms of what your intervention, what you could bring to the table, even if it's not ever written, like even if you send them to an endocrinologist with what it is that they expect to get out of this, and make sure the expectations are aligned. It's not ever really going to be as good as the first time that, you know, this was done, you know. And the other things are, I think that we don't necessarily always do a good job of, is like review their medications. There are medications that some of which are very common that have been associated with weight regain, and you know, some of these can be switched, some of these can be stopped, and some of them can't. And you know, I think at least an awareness of this, even if you're not the one managing their entire medication list, so that you can send them to the right people, is very important as well. Predisposing factors, I think people have already talked about earlier today, but you know, lack of physical activity, diabetes disorders, alcohol consumption, smoking, and some things may predispose or may be a predictor of like weight regain. For instance, patients who lose less than like 500 grams a week 3 to 6 months post-surgery are less likely to achieve maximal total body weight loss of more than 20%, or like patients who start off with a BMI higher than 50. I think this is important because at least, even though it may not be like 100% predictive of the outcome, at least you can maintain greater vigilance in terms of post-operative follow-up and have a tighter follow-up schedule for these patients, which is necessary for like, you know, early intervention. So now we're going to talk about some of the technical issues and workups that of things that could potentially be fixable surgically, you know, for weight regain. Some of these for sleeve gastrectomy are going to be things like a neofundus, retained fundus, or dilated sleeve. Again, some of these are a result of some anatomic issue, like for instance, distal strictures. But some of them are not. They may be, you know, measured by upper GI studies, But overall, I think the trend, at least for now, are that there has been more and more usage of multi-slice CT scans with 3D reconstructions that will allow for a volumetric study of like the actual sleeve volume, post-operatively compared to, immediately post-operatively. Of course, this requires multiple imaging over time, and I don't think this is standard at any one hospital at this point. It's mostly like kind of in the research realm. However, this is promising in that it is a more accurate measurement of the volume that remains, and there has been several studies that have demonstrated that this is related to regain, and that you can help kind of like titrate your intervention based on this. For root-wide gastric bypass, one of the main kind of things to look for, which is fixable surgically, is gastrogastric fistula. This is not very common. The incidence is 1.2%. However, when you do work it up, as it should be part of your workup, there are several modalities that you can use to kind of work this up. One of them is, of course, the upper GI series. But if the hole is small and the contrast doesn't like flow exactly through that hole at that particular point in time, you may miss it. So the sensitivity of that is 58%. The specificity is 98%. But again, the sensitivity is relatively low. A CT with PO contrast is a little bit better, with a sensitivity of 73%, with a specificity of 95%. And EGE has the highest sensitivity, but of course it is invasive. If the hole is really small, of course you can miss it too. Some of the factors that you clue in to kind of like an issue on a CT scan, you may not see the actual track, but you might see some air in a dilated remnant, or like some fluid, or like some dilated remnant issue. Like for instance, in this picture right here, all these things are clues that there is a GG fistula, even if the oral contrast that the patient brings on table doesn't flow directly through the tract. The pouch size of the Roux-en-Y gastric bypass anatomy is also important. There's been studies that demonstrate that an increase in pouch size or the stoma diameter is related with weight regain, or a decrease in the percentage of weight loss, as in this study here. For now, I think the consensus is around optimal stoma size, 1.5 to 2 centimeters. And I think that's why Dr. Crow does his primary hand stoma anastomosis. It's a little bit more difficult to do this with a linear stapler to exactly get 2 centimeters, but it is possible. It's just a little bit more difficult. And I think all of these are related to how you are going to treat this patient, whether it's endoscopically, whether with a surgical revision, and what you're going to offer the patient. So all of this needs to be thought of beforehand and part of your workup for any patient who presents to your clinic with these symptoms. Now the other thing that is important is whether or not there is GERD, right? Because weight regain is not only just a matter of that particular surgery, but all the complications and all the possible things that can happen to them, especially after a sleeve gastrectomy. Does this look familiar, Dr. Crow? All right, so this is a consensus statement with a Delphi 2023, I believe, consensus from 46 MBS surgeons from 25 different countries. Of course, Dr. Crow is represented here. There's nobody from Thailand, unfortunately, but I think the main point of what I want to convey is that what you offer is also related to whether or not the patient has other complications from your surgery, like GERD. All right, because at the end of the day, that is one of the things that may push you more towards a revision, even if their weight regain is minimal, or not necessarily interfering with their comorbid conditions and then come back. But if they have lifestyle limiting GERD, that may be one of the things that push you more towards revisional surgery or intervention. According to this consensus, it was not necessary to do a pH study or a manometry necessarily to prove that you have GERD, but most people, 95%, agree that EGD is necessary. An upper GI study is considered necessary too, with an 82.6% agreement that this is all things that are, basically it's almost like it's part of your physical exam in terms of working out the patient. And if they do have GERD, which I think some people are going to talk about in a second about revisional surgery, then for now, at least, the gold standard or the recommendation is for a room-wide gastric bypass, and that seems to resolve problems. And it's even better if they had weight regain at that point because you hit 2 birds with 1 stone. All right, there is no consensus on when to intervene on patients exactly post-surgery or when to try to get them back on track if they fall off kind of like the normal pathway of weight loss. This is one example that was given in terms of like, how you should follow up patients and like what should happen. Like for instance here, like you have, in the normal pathway is you have like, usual weight loss more than 20% total body weight loss, and yeah, and adequate resolution of comorbidities, then you just like follow them up. But if you fall off of this pathway, right, then that should prompt some kind of action. And I say some kind of action because, as I said, this is only one example of how patients get worked out post-operatively based on the amount of weight they lose. Right? And again, there is no like consensus on when this should happen, like whether it's 6 months, it's 1 year, it's like 1.5 years. Like nobody has said, or like there's not enough evidence to determine like when exactly or how early this should happen. The consensus seems to be though that the earlier the better, but not what earlier means necessarily. One thing that I noticed though was that with a BMI higher than 50, then there should be earlier, more intensive and more aggressive follow-up because these patients tend to do less well. This is just another example of that. Overall, as I said, not exactly like, clear on when the intervention should occur, but anything outside the realm of normal, if persistent in terms of weight loss along the curve, should prompt more aggressive follow-up and potentially work out. So this brings me to my next point, and I'm almost done, is that, follow-up in terms of follow-up post-bariatric surgery, follow-up for anything really is very difficult to achieve. And most of the people tend to disappear, especially if they have a sleeve gastrectomy. They're young, they just want to look nice, and then they're gone. There are good meta-analyses that show that the follow-up at 1 year is around 80 to 90% post any metabolic or bariatric surgery, and this is like an overall kind of picture. There are other numbers out there, but this is the one I picked. At 2 years it drops to 30%, and at 10 years it drops to 10%. It's probably less than that, quite honestly. In what I've experienced, I don't think it's even that high. What I'm trying to say though is that even though the patients may not be local to our area, and this is probably more common in Thailand than in the United States because we have medical tourism, long-term follow-up is possible. And I give this example from a paper that I authored that was just accepted to SWORD, is that this is a program at Geisinger Medical Center where I did my fellowship. Is called the HDP program. So this is employer-based insurance that allows patients to travel from all of these places that are blue to central Pennsylvania to have their bariatric surgery done. Then they get their follow-up remotely with the providers in central Pennsylvania in a multidisciplinary team. Everybody, the dietitian, the surgeon, the gastroenterologist, the psychiatrist, everybody by telemedicine. But what happens before they come and do surgery is they have to sign a contract. Okay? In that contract, they have a designated primary care provider. So if they don't follow up, their provider gets a phone call, and then they're made to basically follow up. With this model, it is possible to achieve an 82% follow-up in 1 year and 63% follow-up in 2 years. So all I'm trying to say from this is that it is possible. It's hard, but it needs to be done because ultimately what is going to happen is that when people fall off the curve, nobody notices because they don't come back. And I think the model in the United States in terms of like having a national database with the NBSA, but it's great, and we're trying to achieve that locally in Thailand as well. But these are all retrospective, even with patient-reported outcomes, and the same goes for in England. What we would like to see more, though, is having things that are live, I guess. And the Cleveland Clinic does a very good job in terms of predicting when certain complications will occur with their list of calculators. If you guys haven't seen this, you just have to type in clinic risk calculator and it will like show up a bunch of things. But what I'm trying to say is, especially in this day and age, when you have electronic medical records almost everywhere, where you have AI, all right, it is possible to potentially integrate this into a live, real-time follow-up of the patients, even if they don't come back to the surgeon, even if there's just a notification saying, okay, this person's having weight regain, send it back to the surgeon. Okay, and this is what happens at Kaiser for other diseases, not for bariatric surgery. And there has been some studies that demonstrate that you could potentially use this as a solution. But the problem right now, and I think it's going to be a persistent problem for a while yet, is that it's not reliable. It's biased based on that particular institution's outcome. So once all of these things are resolved, I think things will get better. But in the meantime, I think our job is that we need to ensure that patients follow with us, because obesity is a chronic disease. Surgery is not a cure. And yes, it starts with engaging in very serious pre-operative conversations with the patient that they need to uphold their part of the deal even after surgery. That it's not like a one and done deal. But we need to be able to catch those people who fall off the curve, and we need to do it early. Well, thank you for your attention. I'm actually interested to see what Dr. Crow says. It's like the general algorithm nowadays includes that.
Thank you for your excellent discussion. Does anybody have any questions or have anything to discuss? All right, let's move on to our next speaker. Our next speaker is Assistant Professor Patchaya Punjayanan. She is an endocrinologist at Chulalongkorn Memorial Hospital. She will speak on the role of multidisciplinary care team